This is Dr. Mimi Lamb, and I would like to explain the basic types of renal replacement therapy, or RRT, that are most commonly used in the intensive care unit. In this overview, we'll be talking about these three methods: hemodialysis, continuous veno-venous hemofiltration, or CVVH, and continuous veno-venous hemodiafiltration, or CVVHDF. First, let's start with some basic terms that describe the mechanisms by which fluid and solute can be transported with RRT. Diffusion is the movement of solute across a semi-permeable membrane down its concentration gradient. Ultrafiltration is the movement of plasma water across a semi-permeable membrane driven by a pressure gradient across the membrane. And convection is the movement of solute dissolved in plasma water across a semi-permeable membrane. As the plasma is ultrafiltered, the dissolved solute is carried along by solvent drag. Now, what are the basic types of renal replacement therapy? Let's look at them one by one. With hemodialysis, the patient's blood is circulated past a semi-permeable membrane with dialysate solution on the other side. Plasma composition is altered primarily by diffusion of molecules down their concentration gradients to or from the dialysate solution. Plasma volume, as we'll see, can be decreased by ultrafiltration, and hemodialysis is performed in sessions that typically last between 2 and 4 hours. Here's a diagram of how hemodialysis works. Here's the semi-permeable membrane with the patient's blood on one side and dialysis solution on the other side. The membrane contains many tiny pores which hold back larger elements like proteins and blood cells, but allow the small molecules to pass through. The dialysate contains low to zero concentrations of solutes that are to be removed, like potassium, urea, and creatinine, and higher than normal concentrations of substances that are to be added to the plasma, such as bicarbonate. Solutes that do not need to change much in concentration during dialysis, like sodium and calcium, are present in the dialysate at physiologic concentrations. Although the very first dialysis membranes were flat and about the size of a coffee table, current dialyzers achieve more surface area in a compact space by being made in the form of capillary-like hollow fibers with fenestrations along their entire length. The patient's blood flows through the capillaries, and dialysate solution flows past the outsides of the fibers. Dialysis has been around for a long time, first being developed during World War II for use in soldiers with acute kidney injury. But in 1977, continuous renal replacement therapy methods were first developed that essentially spread the procedure of dialysis over 24 hours instead of doing it all in 4. Today, the main methods of CRRT that we use are CVVH and CVVHDF, and we'll look at a brief description of each. In continuous veno-venous hemofiltration, or CVVH, venous blood flows at a slow rate through a hemofilter consisting of hundreds of semi-permeable capillary fibers, just like a dialyzer, but smaller. Negative external pressure can be used to create a gradient across the membrane that allows plasma water to be ultrafiltered and removed, dragging solute with it. The ultrafiltered plasma water, which contains all of its usual small solutes, such as sodium, creatinine, urea, and calcium, is replaced by a fluid similar to dialysate. Over the course of 24 hours, many liters of plasma water are gradually removed and replaced with urea and creatinine-free solution. Thus, solute and fluid balance is altered by a combination of ultrafiltration and convection. Convection can remove larger molecules than diffusion can. With hemodialysis and diffusion, for instance, only very small molecules, such as creatinine, molecular weight 113, urea 62, sodium 23, etc., can be efficiently removed. In CVVH, the use of convection allows the so-called middle molecules, molecular weight 500 to 60,000, to be removed as they are dragged through the semi-permeable membrane along with water. In continuous veno-venous hemodiafiltration, or CVVHDF, hemofiltration occurs as described above, but the hemofilter is also exposed to dialysate, so that the plasma composition and volume are altered by a combination of ultrafiltration, convection, and diffusion. Let's look at the setup for each of these three procedures. In dialysis, the patient's blood flows through the hollow fiber dialyzer in this direction. Dialysate flows through the dialyzer cartridge, bathing the capillaries with metabolic waste products diffusing out of plasma into the dialysate. Note that the dialysate flows in the opposite direction from the patient's blood. This maximizes the concentration gradient between plasma and dialysate as much as possible along the length of the capillary. In other words, if blood and dialysate traveled in the same direction down the dialyzer capillary, by the time the blood had traveled the length of the capillary, much of its urea and creatinine would have diffused into the dialysate so that the gradient for diffusion would not be nearly as good. Having dialysate flow in the opposite direction allows the blood at the end of the capillary to meet fresh dialysate containing zero urea and creatinine, thus allowing efficient diffusion to continue. Ultrafiltration can also be employed by adding negative pressure to the airtight dialysis cartridge and pulling plasma through the capillary pores to reduce the patient's extracellular volume. Hemodialysis is typically performed in sessions lasting 2 to 4 hours. Here is an actual dialysis machine, and you can see the patient's blood flowing through the dialysis cartridge in this direction, its rate being controlled by a roller pump. The dialysate, meanwhile, is continuously made by mixing concentrated components with purified water from large tanks behind the machine, and it flows in this direction into the dialysis cartridge, back out again, and it's discarded down the drain after a single pass. The screen of the dialysis machine shows such data as the most recent vital signs, the patient's blood flow rate, the amount of ultrafiltrate to be removed from the patient during the session, here 4 liters at the rate of 950 cc's per hour, with 2422 already being removed, the amount of time left in the dialysis session, 1 hour and 41 minutes out of 4 hours, the temperature to which the patient's blood is warmed in the tubing while it is outside of the patient, the flow rate and composition of the mixed dialysate, and the pressures within the blood lines that are leaving the patient, negative because the roller pump is pulling blood out, and returning to the patient, positive because the blood is being pushed back into the patient's vein. Note that with both dialysis and CVVH, when a dual lumen dialysis catheter is used for access, the exiting and entering blood lines are actually both venous blood. They are labeled arterial and venous only so that we can keep track of which one is leaving the patient and which is entering. In CVVH, the patient's blood again flows through a hollow fiber hemofilter, which is similar to a dialysis cartridge but smaller, since the blood flows needed for this 24-hour procedure are lower than those needed for a 4-hour dialysis. The droplets of ultrafiltered plasma are collected in large bags and measured, and are replaced with a dialysate-like replacement fluid, which can be infused into the blood circuit either before or after the hemofilter, or both. The patient's extracellular volume is altered simply by adjusting the balance between the volume of fluid pulled off by ultrafiltration and the volume added as replacement fluid. Replacement fluid is essentially the same as dialysate, containing little or none of solutes to be removed from the patient's blood, such as creatinine, urea, phosphate, and potassium, larger amounts of solutes to be added from the fluid to the patient's blood, such as bicarbonate, and normal concentrations of solutes that usually do not change much during dialysis, such as sodium, chloride, and calcium. And of course, there are no proteins or big molecules. The big question about replacement fluid is, where in the circuit should it be infused, before or after the hemofilter? Post-filter seems to make intuitive sense, so that fluid can be removed by ultrafiltration, then immediately replaced with urea-free, creatinine-free fluid. But the problem with post-filter replacement is that pulling off large amounts of fluid by ultrafiltration increases the hematocrit and protein concentration of the remaining blood, leading to clogging of the hemofilter pores, which is made even worse by adsorption of protein molecules to the filter membrane. However, this problem can be partly counteracted by increasing the blood flow rate in the filter because the sheer effect of blood flow tends to decrease protein adsorption. On the other hand, infusing replacement fluid before the filter keeps the pores from clogging, but results in removing some of the fluid before it ever reaches the patient and diluting the concentrations of stuff to be removed before the fluid gets to the hemofilter. In some institutions, ours included, a mixture of pre-filter and post-filter replacement is used to avoid extremes of the pre- or post-filter problems just described. Here's how a CVVH machine looks. Again, we have the patient's blood running through the hemofilter, its rate being controlled by a roller pump, and ultrafiltrate is collected in one bag while replacement fluid is infused before and after the hemofilter. The second type of CRRT commonly used in the ICU is CVVHDF, continuous veno-venous hemodiafiltration, which is simply a combination of CVVH and dialysis. Here the patient's blood passes through the hemofilter and large amounts of ultrafiltrate are removed and then replaced with creatinine and urea-free replacement fluid. But now the blood in the hemofilter is also exposed to dialysate, which enhances solute removal by using diffusion in addition to the convection that is already happening with CVVH. Now let's look at two more specific issues involved in choosing and running the different forms of RRT. We'll talk about vascular access and anticoagulation. Vascular access is via either a temporary or a subcutaneous tunneled central venous dual lumen dialysis catheter. As with most central venous lines, either the internal jugular with the catheter tip in the SVC or the femoral vein is used. The blood flow rate is controlled by a roller pump, so the central vein needs to be able to supply up to 400 mL per minute of blood flow. This is a dual lumen dialysis catheter, which is essentially two catheters placed side by side, each with its own lumen at the tip, and each with its own side pores, allowing for better blood flow. Blood flow is in this direction, and the exiting blood is pulled from the more distal pores, while the returning blood enters more proximally to minimize mixing between dialyzed and undialyzed blood. In other words, you want to avoid returning freshly dialyzed blood to the patient only to have it pulled right back out and sent back to the dialyzer. Anticoagulation is needed to prevent clotting within the tiny capillary fibers of the dialyzer or the hemofilter. If anticoagulation is contraindicated, periodic saline flushes may be used to prevent clotting. Otherwise, heparin boluses or infusions may be given, and more recently, the use of regional anticoagulation with citrate has become popular. With this technique, citrate is infused into the blood circuit before the hemofilter. It complexes with calcium, interfering with the normal process of coagulation as the blood travels through the capillaries. In order to avoid anticoagulation in the patient's circulatory system, calcium is infused just before the hemofiltered blood returns to the patient, so that serum ionized calcium is normalized. In other words, only the hemofilter is anticoagulated, the patient's coagulation cascade remains intact. So, to recap, citrate is given pre-filter and complexes with calcium to impair coagulation within the filter. Calcium is given post-filter and restores normal calcium levels and coagulation ability before the blood returns to the patient. The calcium citrate complexes that are formed are cleared in the effluent and also metabolized by the liver and muscles. This type of regional anticoagulation minimizes the bleeding risk for the patient and also can potentially decrease pro-inflammatory effects of ionized calcium. Things that can potentially go wrong with the complicated process of citrate anticoagulation include metabolic acidosis if citrate metabolism is impaired, for instance, because of liver disease, which allows citric acid to accumulate. You can also get metabolic alkalosis if the rate of citrate infusion is too high, so that citrate is metabolized to bicarbonate, and you can get low ionized calcium levels if the citrate infusion rate is too high or if calcium rate is too low. Finally, let's summarize and compare the three different modalities of RRT that are most commonly used: hemodialysis, CVVH, and CVVHDF. Notice that the blood flow rates of the continuous therapies are lower than for a 4-hour dialysis. Dialysate flow rates are also lower in CVVHDF, only 15 to 35 mLs per minute, compared with 500 to 800 for hemodialysis, again because of the 24-hour duration of the treatment. While hemodialysis can pull off 1 to 2 liters of fluid per hour net, CVVH and CVVHDF remove several liters per hour all day long, but replace the volume so that the patient does not become intravascularly volume depleted or experience large swings in blood pressure. Notice that with CVVHDF, the amount of ultrafiltered fluid removed and replacement fluid added is often not quite as large as with CVVH alone, because dialysis is helping to clear solute too. So the net fluid removal in all three therapies can be about the same, but is accomplished in 24 hours instead of 4 with the continuous modalities. Note that the clearances of small molecules in both types of continuous therapy are about the same, even though CVVH uses convection only, while CVVHDF employs convection and diffusion. The reason for the equal clearances is that small molecules diffuse readily across the membrane so that they are very efficiently removed by either dialysis with diffusion or CVVH with convection. Wow. However, middle molecules, molecular weight 500 to 60,000, are more efficiently removed by convection than diffusion, so CVVH and CVVHDF are better at removing them than dialysis alone is. The reason this is of interest is that a recent study identified 67 so-called uremic toxins, the substances that make people sick in renal failure, 22 of which fell into the middle molecule range. Other potentially pathogenic middle molecules that have been shown to be cleared with the convective therapies include various cytokines, chemokines, myocardial depressant factors, and proteins involved in complement activation, all of which could play a role in patients with sepsis and heart failure. So the factors that we take into consideration when deciding on the best method of RRT for a particular ICU patient include things like these: if the patient has an unstable hemodynamic or volume status, or is at risk for cerebral edema, the slow continuous modalities are much better tolerated than a 4-hour hemodialysis, which may induce wide swings in volume and blood pressure or rapid shifts between body fluid compartments. On the other hand, if the patient is hemodynamically stable but extremely catabolic, hyperkalemic, or fluid overloaded, the rapid removal of solute or fluid by hemodialysis may be needed. If middle molecule clearance is desired, CVVH or CVVHDF is the treatment of choice. So in summary, the types of renal replacement therapy that are available for use in the ICU setting include intermittent hemodialysis, which efficiently removes fluid and small toxins, but which may induce fluid and electrolyte shifts that are poorly tolerated by the very ill or hemodynamically unstable patient. For such patients, the continuous therapies, such as CVVH and CVVHDF, provide slow continuous removal of solutes and fluid, and in addition do a better job of clearing so-called middle molecules that may play a role in producing disturbances seen in uremia and sepsis.